So I'm just going to jump right in. I'm going to present selected research findings from what we've been doing over the years. And of course, the point of this slide by David Skidmore, who's a patient as well as a cartoonist. He has a book of cartoons on Lyme disease. He's at the top of the mountain saying, we have Lyme disease and we need help, please. So that's why we're having this conference. I thank the organizers for organizing this great conference with some really terrific speakers. I've learned a lot, so thank you. We get funding support from different places at different times: the National Institute of Health, New York State, the Cohen Foundation, FDC Foundation, Global Lyme Alliance, and of course, without our donors and our institutions, we wouldn't be able to do this work. So I want to put together this slide, which gives an idea of the different balls that we have up in the air at different times. And they're all connected through collaborations. So one really wonderful thing about these conferences, as well as the national conferences we have in the US, is the ability to establish collaborations with colleagues. And one thing that has been particularly fruitful for collaborations has been to establish a sample repository, which has enabled us to collaborate with colleagues on proteomic and metabolomic and metagenomic studies. I'm a psychiatrist, I can't do that stuff, but certainly we can collaborate and do excellent clinical evaluations of patients as well for them. So that's been great. We, as a psychiatry institute and neuropsychiatry institute, do a lot of brain imaging. So that's strong in our group, and we're doing fMRI studies and MR spectroscopy studies of patients with central brain pain, persistent pain after Lyme disease treatment. We do treatment studies as well, as you know. We've done antibiotic studies, and recently we have been venturing into Kundalini yoga to see if that might help patients who have persistent pain and fatigue. So we have a paper in preparation on that, and hopefully a new online study that will emerge in the next few months. We have a collaboration going on with Michael Benrose and his outstanding epidemiologic group in Denmark, looking at psychiatric disorders after Lyme borreliosis. I mentioned we have conferences, we have the book. And interestingly, over the years, we've gotten calls from family members saying, my relative, my father, my sister, or whoever is about to die, and could we donate tissue, brain tissue perhaps? And so we collected some of these brains and other tissues, not knowing exactly when we were going to probe them or how to go about doing that. But we have an excellent neuropathology group, so we stored those samples, and now we're in the process of evaluating the neuropathology of some of those well-characterized specimens and sharing them with Monica Embers at Tulane University so she can probe using her outstanding molecular techniques to look for Borrelia, and I believe I know she's also looking at Bartonella in those specimens. And in addition, we do neuropsychological testing, and my colleague John Kalb has done a great job clarifying what the neuropsychology profile is of patients who have persistent symptoms related to Lyme disease. And usually it's decreased verbal fluency, some short-term memory problems, and slower processing speed. And finally, we have collaborated on diagnostic and co-infection studies, and I'll tell you a little bit about that in our talk. So briefly, I like to show at the beginning what we're going to be doing so you don't get lost. I'm going to talk a little bit about our brain imaging studies, mainly PET imaging. Our MRI studies did not show any difference between patients and matched controls. These are patients with chronic Lymeencephalopathy. I thought there would be significant differences, but there weren't on MRI. I'm going to talk a bit about the Lyme C6 peptide ELISA, which others have mentioned here, as well as an investigation with an intrathecal antibody version of the C6 peptide ELISA. We're doing a Powassan virus study with Peggy McDonald at Rockefeller University now, looking for neutralizing antibodies, hoping that that might lead to a treatment for this deadly disease. But I'm not going to talk about that. I will talk about our study on Borrelia miyamotoi antibodies. I will talk about our general symptom questionnaire, which we published just last year. It's an instrument for assessing Lyme disease symptom burden. And finally, I'll end up talking about treatment studies and future directions. So that's what I hope to do in the next 40 minutes or so. So here's a beautiful image of the metabolic deficits in red and yellow there among the group of Lymeencephalopathy patients, well-characterized Lymeencephalopathy patients compared to well-matched age, education, and gender-matched controls. So it's clear that there are multiple areas of decreased metabolism, primarily in the posterior parietal area and the temporal area. In addition, we found diminished ability to enhance global blood flow in the patients compared to the controls. So the cerebral blood flow was enhanced only 8% after what's a carbon dioxide inhalation challenge on PET scan versus a 28% enhancement in the controls. So there's something limiting the enhancement of blood flow. So there's a suggestion of vascular compromise as well in the patients with persistent cognitive impairment after well-documented Lyme disease. So now just to go to the C6 briefly, we collaborated with Euroimmune, which is an excellent European diagnostic study in Lübeck, Germany. And we looked at some standard tests, the C6 ELISA, as well as some of the Euroimmune tests. And interestingly, we looked at convalescent EM cases. So this is not fresh EM, these are patients about 4 to 6 weeks later. And we looked at how sensitive and specific the different assays were. And the C6 peptide ELISA did surprisingly well with 94% sensitivity and 93% specificity. That's not ideal specificity, but it's not bad, especially for that degree of sensitivity. The IgG Western blot did quite poorly. The IgM did a bit better, but the combination at the bottom, you see the C6 and the VLSE IgG was 81%, 82% sensitive and 98% specific. So at least at 4 to 6 weeks on this study, it looked like the C6 did quite well as a single test. Now, Immunetics at the time was marketing the kit and developed the kit for that test, and they also had developed a spinal fluid version of the test. So we sent them samples blindly, actually. We also sent them samples from spinal fluid and serum of patients with schizophrenia just to see what they found. And lo and behold, the C6 ELISA index was found to be 4 times more sensitive in detecting Pirelli antibodies than the whole cell sonic ELISA assay that we sent to Stony Brook, a different lab. So that was exciting for us, just to see that there was a much better intrathecal antibody test. And then the question is, though, who cares? Does this have any clinical significance for post-treatment Lyme disease? And the standard teaching, of course, is that if you have patients with an infectious, a neurological infection, and you treat them with antibiotics for their bacterial infection, and they will still have antibodies, intrathecal antibody production for years later, perhaps. And so the thought is that the intrathecal antibody production that persists really doesn't mean anything. So I'm going to show some data that challenges that belief. So here you see the baseline short form 36 physical component scale score. These are all the Lyme patients here, and here's a group of healthy controls. So they're all scoring pretty low. 50 is roughly normal, 35 is quite impaired. So they're all about the same. These are the patients who got drug who are C6 positive. These are the patients who got placebo who are C6 positive. And you can see they're falling, a small number of patients, but you can see that they're falling at pretty much the same level on the physical functioning index. No difference. But after the given ceftriaxone, those patients who are C6 index positive showed a robust improvement in their physical component score at week 12, which was they got 10 weeks of IV ceftriaxone. The placebo-treated group, on the other hand, did not show any improvement, even though they were also C6 index positive, and neither did the placebo-treated groups. So this was totally fascinating, and it does raise a question. Is there clinical benefit that might be obtained by knowing whether someone still has a intrathecal antibody production if you're using the C6 index? And could it be a useful biomarker to identify patients more likely to respond to repeated antibiotic therapy? In this case, it was repeated IV ceftriaxone therapy. All the patients who entered this study had already been treated with IV ceftriaxone. So it was unlikely that they were going to respond again, but at least the C6 index positive patients did. So we also had a co-infection study that we've been doing over the last couple of years. Shannon Delaney, who's a wonderful colleague who works with me, just recently got this accepted for publication in Frontiers in Medicine. And the question is, could Borrelia miyamotoi account for seronegative Lyme? You heard this recently. Are we looking for the wrong culprit, as one of our prior speakers stated? So among 82 patients who came to our second opinion clinic for suspected Lyme disease, and they come from all around, but mainly the northeastern United States, and they've often been sick for years and been on lots of antibiotics. And so our challenge is to try to figure out how to help them. But one of the things they come in with is oftentimes they don't know what they have, and they've tested negative for the Lyme test on the Lyme assays that were previously conducted. So we conduct a whole range of co-infection tests, including the Borrelia miyamotoi GLPQ IgG antibody assay that Imugen was offering at that point. And so we looked to see how many tested positive on that and what percentage of patients had previously been tested for Borrelia miyamotoi. And what we found was that a quarter of the patients tested positive on this antibody assay at our clinic. But only 2 of the 82 patients had ever been tested for Borrelia miyamotoi before. So why in the world would that be the case? Well, number one, Borrelia miyamotoi is a relatively new tick-borne infection. The vast majority of doctors are not aware of this infection. And I can say that it seems like quite a few infectious disease doctors and rheumatologists are not aware of this tick-borne infection. And they certainly should be, but they're not. So there's an education problem that exists. We did look to see whether there were any clinical differences between patients who presented with Borrelia miyamotoi antibodies, but no Burgdorferi antibodies, and patients who presented, and what we found compared to those who had only Borrelia antibodies, and we found that they had significantly more sleepiness and pain. Now, I don't know if this is a real finding or just a finding because we looked at multiple different symptoms, so this may not have any validity at all, but there's a suggestion at least that sleepiness and pain may be more elevated in the Borrelia miyamotoi patients. So the message is, for seronegative patients with Lyme-like illness, test for Borrelia miyamotoi, and the research needs obviously are clear. Does Borrelia miyamotoi lead to chronic or relapsing symptoms? What is the optimal antibiotic therapy? We should obviously, in this study, we should have been doing PCR assays on all patients, which we didn't do, but we will in the future. And do patients with dual Borrelia burgdorferi and Borrelia miyamotoi infection have a more challenging clinical course? This is a new disease. It's wide open for study. So I'm happy to see that this conference has quite a bit on Borrelia miyamotoi. And I was really intrigued yesterday by the talk showing that the Borrelia miyamotoi was found in multiple organs by Dr. Zink up in Canada in the animal reservoirs. That was fascinating. So now I'm going to move on to measures. What measures are sufficient for clinical trials and precision medicine studies? We have our legacy measures, which everybody's using over and over again. The fatigue severity scale, I think it's quite good. SF-36 for physical mental function, I think that's pretty good too. McGill pain scale is primarily a visual analog scale. That's good as well. But what we don't have yet is a measure that captured multi-system involvement of Lyme disease. And so that's why we created with John Alcott at Hopkins and Nev Zubčević at Harvard, the General Symptom Questionnaire, GSQ-30. It's simple, it's easy to use, it's 30 items. It's really meant for clinicians and their practice. Give it right before the patient comes in the office or while they're there with you, they can fill it out in just a few minutes. And it targets the symptoms that are causing the greatest problem for them. So that can be informative, and it's good for, I think, for researchers to assess the symptom burden. How much is it bothering the patient? And it also you can use it to assess change over time. So we did a validation study with 222 Lyme disease patients, some with erythema migrans, many with post-treatment Lyme syndrome. We compared the group to those with major depression, another group of traumatic brain injury patients, and healthy controls to see if the GSQ could distinguish between the groups. and it really couldn't. There was some differences with TBI and Lyme disease, but at least with PTLDS, it couldn't differentiate. PTLDS has a lot in common with depression and TBI. So here's what it looks like. This is the first 11 items. So very simply, during the past 2 weeks, how much you've been bothered by any of the following symptoms: shortness of breath, feeling feverish, sweats or chills, nausea, vomiting, back pain, headaches, stiff neck. So a lot of viral symptoms. And then later on, it goes into neurologic symptoms, sleep symptoms, as well as neuropsychiatric and neurocognitive symptoms. And then at the very end, we ask, it's not included in the scoring, but at the very end, we ask, over the last 2 weeks, have any of the above impaired your work, social, or family functioning? And that's extremely important because some patients rate things very highly, but it's not impairing for them. So you as a clinician in particular, in your practice, would want to focus on what's most impairing for the patient. The validation study showed that the scale has excellent internal consistency. We identified 4 factors within the scale. There was the neuropsychiatric cluster, the neurologic cluster, the viral-like cluster, and the pain fatigue cluster. It'll be really interesting to see if some of those clusters are associated with different precision medicine biomarkers. We showed that the GSQ-30 was sensitive to change over time. And we also showed that it's not just a measure of symptoms, because we showed that the GSQ-30, when it changed over time, it correlated with other measures of functional impairment. So it truly assesses symptom burden. Now here's what I think is a really interesting graph or figure. And what this shows is at the beginning, when patients present with erythema migrans here on the left, all patients were clustered in a group of erythema migrans patients. And then we followed them up over 6 months after doxycycline treatment to see what happens to them. And a small portion of patients who were in this EM group at the beginning developed or had persistent symptoms with functional impairment. So they were characterized as post-treatment Lyme disease syndrome. Another group had no impairment, but they did have symptoms that bothered them. So that was a symptom-only group. And this is the return to health group. And quite interestingly, if you go back to baseline, so you see what they're like at 6 months, then you go back to see what was their GSQ like at baseline. What you see is those who returned to health had very few symptoms at the start. Those who had symptoms only at 6 months had a moderate level of symptoms. And those who stayed with PTLDS or developed PTLDS had a very high level of symptoms at baseline. So the question is, can we use something like the GSQ-30 to correlate it with immune markers or psychiatric markers to see what are the predictors of perhaps poor outcome? And can we do something at baseline at the time they present with their rash or their initial infection to treat them differently or more aggressively so that they don't go on to have persistent symptoms causing functional impairment or not? So that's fascinating to me. So anyway, the GSQ-30 is a psychometrically sound measure. It should be useful. It's not a diagnostic instrument, and it might be useful for precision medicine studies. So now I'm going to go into treatment. A little bit about our prior work, some new work, and future directions for the field. So as you all know, or many of you probably know, we conducted this Lymeencephalopathy study, which I mentioned earlier, using 10 weeks of IV ceftriaxone versus placebo. Primary outcome was 12 weeks, and we followed people up to 24 weeks. This group was highly chronic in the sense that they had a mean amount of prior IV treatment of 2.3 months. They had a mean amount of oral treatment over the years of 7.7 months, so they had been aggressively treated in the past. Often there was a delay in symptom onset and treatment, so that might have contributed to their chronicity. But as you can imagine, when you're doing a treatment study, in many ways, we were loading or biasing our treatment study for failure because these patients were all patients who had either not responded well or relapsed after their antibiotic therapy. So the fact that we found anything in this study that was potentially positive to me is remarkable. First of all, it was a small sample size. We had 23 patients treated with drug and 14 treated with placebo. So with such small sample sizes, you don't expect to see much of anything. And what our primary outcome was cognition. And here you see the cognitive score, the Z-score, and the patients given drug were a little bit lower. They did improve up to 12 weeks, but then they lost all their gains by 24 weeks. So there was absolutely no sustained improvement in cognition for these patients. The placebo group showed a gradual improvement over time, which if you just connect to the two dots here, you get the same trend. And the healthy controls also showed a gradual improvement in time. And that's probably because they're repeating the same neurocognitive tests, they're familiar, so they're improving. So from a cognitive point of view, the 10 weeks of IV ceftriaxone really did not do much. However, if you look at the secondary outcome measures, and this was the physical component scale, the short form 36 physical functioning composite score, what you see that those who got drug compared to placebo did in fact show a separation with improvement that was in fact sustained out to 24 weeks. So from week 10 to week 24, they were on no antibiotics. And in fact, we also saw a sustained improvement in fatigue, another secondary outcome measure. And you see that here, 64% of patients on ceftriaxone improved compared to only 25% on placebo. Similarly, this almost identically replicated what Lauren Krupp showed several years earlier at her Stony Brook, Long Island study, where she gave 1 month of IV ceftriaxone to patients who had been previously treated. And her primary outcome was fatigue, and she showed 64% improvement on the fatigue scale in terms of 64% were responders compared to 18% response rate for the placebo group. So when you have two studies that show very similar results that were done differently, but using the same measures, you tend to believe the results that repeated antibiotic therapy can be helpful for patients with persistent fatigue. So we did a 10-year follow-up recently of our persistent Lymeencephalopathy sample, and this is what we found. We wanted to know, did they get better? Did they stay better? Did they get worse? What happened? And did their course differ from the course of the healthy controls? We didn't have many healthy controls. We had 18 healthy controls, but we tried to track them down 10 years later, which, as you can imagine, isn't easy. So we were like private investigators tracking people down. And the Lyme patients were very generous and responded, and we had 81% follow-up information on those patients. 1 had died, 6 were lost to follow-up, 1 decided not to participate, and 29 did agree to be interviewed. And then on the controls, we were able to track down 11 controls who agreed to participate. So that was encouraging. And this is our main question. To what extent do you feel Lyme disease is affecting you now, roughly 10 years after completing the study? Not at all, a little bit, but not in a meaningful or significant way. So it's really not bothering you. Moderately, but I am able to function, or severely, and it impairs functioning. Now, this is obviously highly subjective in the sense that it's patients reporting that they feel that their current symptoms 10 years later are related to the Lyme disease that they got many years earlier, more than 10 years earlier. And obviously over the course of 10 years, many things can happen to a person. But this is the question that we asked. What we found was basically the rule of thirds. A third of the patients were actually doing extremely well and said it wasn't bothering them at all or only a little bit. Another third were doing reasonably well in terms of functioning. They were able to function, but they had moderate symptoms. And then a third were severely impaired and not doing well. So we asked a question of the group in addition about symptoms, to rate the severity of their current symptoms at follow-up. And we then asked which severe symptoms at follow-up are more common among the patients compared to the controls. So was it sleep? Was it pain? Was it numbness, fatigue, memory loss? What was it? And what we found was really that it was the pain symptoms that differentiated the Lyme patients from the controls most commonly. Muscle pain, nerve pain, joint pain, and of course fatigue. If you've got a lot of pain, you're going to also have substantial fatigue. And interestingly, if you remember in the GSQ-30, the factor analysis, it was pain and fatigue that clustered together. in the factor analysis. So this independently demonstrates that there's something that goes together, pain and fatigue. But it also says that we need to focus on how to help patients with persistent pain who have already received quite a bit of antibiotic therapy and maybe come up with other ideas for them. We compared their scores at baseline before our study 10 years earlier, compared to how they were doing 10 years later. And there was indeed significant improvement over time on the pain ratings, fatigue, physical functioning, mental functioning, depression, and anxiety. So that was highly encouraging. And here it shows in green as the Lyme patients, they improved quite a bit in fatigue to week 24, and then that continued to go down over time, whereas the healthy controls got more fatigued as they got older, and so they started to do a little bit worse. And the Lyme patients continued here to make progress in physical functioning, whereas the healthy controls started to decline in physical functioning as they got older. So the good news from this follow-up study was that severely ill patients can get better. Nearly a third are fully well at follow-up. The change over time, actually with age, aging 10 years favors the Lyme patients. They did better than the controls in terms of their trend. But patients continue to have more severe symptoms than controls, at least those that were still symptomatic, primarily neuropathic and musculoskeletal pain. And we need to focus on that. So what are we doing now? We're doing a study looking at Disulfiram, as many of you know. It's a pilot study to assess how well is Disulfiram tolerated. And we're comparing 4 weeks versus 8 weeks of treatment. It's not a very long treatment. And we wanted to see how they do on various measures because we're thinking of doing a larger randomized trial, but we only want to do it if it's safe, a safe treatment. And we only want to do it if we see a good signal of improvement with Disulfiram on some of the important pain or fatigue or other measures associated with post-treatment Lyme syndrome. It's too early to report results. We have to stop for COVID-19, but we're resuming now, and hopefully we're going to resume in a telemedicine fashion, which will enable us to complete the study in the US much faster. Kundalini Yoga is pretty fascinating, and as I said, we're going to be launching a online study in the US as well in the near future. Now, Disulfiram, just a couple of slides about Disulfiram. There's multiple modes of how it might actually be helping patients. Obviously, the work against persisters is totally fascinating, and I'll mention that briefly in a couple of slides. But it has been shown over the years in vitro to have many antimicrobial effects against bacteria, parasites, viruses. It also intriguingly has anti-inflammatory effects, as has been shown to inhibit the NF-kappa B pathway. And it also, because it interferes with the dopamine breakdown into norepinephrine, Disulfiram actually enhances brain dopamine function, which can lead to an energizing effect and some euphoric effect, perhaps. And it also can cause anxiety and, in some cases, mania. So it can be a positive as well as a negative. Now, the risks associated with Disulfiram, commonly, they're not really major. I mean, it's an old drug. We know a lot about it. Fatigue, headaches, acne, reversible impotence. So those are mild and reversible. The real risk is the alcohol Disulfiram reaction, in which you can get facial flushing, palpitations, nausea, vomiting, cardiovascular collapse, seizures, death. So obviously, we are very, very careful in educating our patients about the multiple different sources of alcohol, including in foods, including in personal hygiene products. It's dangerous. And then high-dose Disulfiram or prolonged treatment with Disulfiram can increase risk of liver toxicity, and rarely, fortunately it's rare, but it's scary, liver failure has been reported. Peripheral neuropathy is not common, but it can occur, and rarely you can get mania or psychosis, as I mentioned. So Disulfiram needs to be treated with respect, and certainly alcohol has to be absolutely avoided in all forms, including a sandwich where you might have red wine vinegar in your lettuce. So be careful if you're taking Disulfiram. Now, there's been a number of wonderful in vitro studies and some emerging animal studies looking at the target persister Pirelli infection. Certainly Dr. Zhang's lab has been leading in that area. And they recently published a paper in which they used this triple antibiotic combination of daptomycin, doxy, and ceftriaxone, and showed that Borrelia were cleared in the mouse model. They showed in that study that ceftriaxone cleared the log phase Borrelia, but not the stationary phase Borrelia. It really required the triple antibiotics to do that. They also showed that the stationary culture was associated with more severe arthritis, and so that was interesting as well. Now, unfortunately, daptomycin and ceftriaxone requires intravenous administration. Intravenous administration, especially with PICC lines and indwelling lines, increases the risk of blood clots, thrombi, death from sepsis. So it's not mild, or it's not a mild problem if you have a PICC line or an IV problem. But if you're extremely ill and this combination works, it's something that might be worth studying further in a human study. Dr. Zhang's group also reported on essential oils from herbs and other spices, a bunch of them that looked really interesting. But again, you have to remember, in vitro doses are often massively higher than in vivo doses, and you don't know exactly what components in the garlic or cloves or myrrh or thyme is the potent effect. So these are all studies in development, and patients should not be going out there and taking massive amounts of this stuff, hoping that that's going to help them. Dr. Lewis's lab at Northeastern University in the States has reported that pulse IV ceftriaxone, vancomycin, disulfiram are very powerful in eradicating persisters. Dr. Rajadat's lab at Stanford has reported also on a whole bunch of compounds, most recently on aslocillin, and also on disulfiram. And he also reported a mouse study in which disulfiram was used, showing that it was helpful in killing various forms of Borrelia, including persisters. Okay, future directions. So should biomarkers or clinical history change the initial treatment duration or choice? I mentioned that maybe people who score high in the GSQ-30 should have a different approach. Maybe those who have had a delay in the onset of treatment since symptom onset should have a different approach. And maybe those who have a high allopathic load, meaning a high burden of illness in general, people who have had multiple prior infections from other causes, or traumatic injury, or carry a heavy burden of disease, maybe those patients should have a different approach as well, because they might have poorer outcome. Or should it be based on immune markers, such as CCL19, which John Alcott's group at Hopkins identified as a potential predictor of PTLDS? Or Clemens Sterl at Harvard identified IL-23 as being elevated in patients at baseline who subsequently went on to develop PTLDS. Or intrathecal Borrelia-specific antibody production in the CSF. So all those are potential markers, and I'm sure there are many more. And other physiologic targets perhaps should be considered in modifying the immune to improve outcomes. So should we be modifying the immune response? Alan Steer's group at Harvard uses hydroxychloroquine for patients with persistent Lyme arthritis symptoms. Minocycline, we know, is active against Borrelia, and we know also that minocycline is very good at reducing central nervous system inflammation and microglial activation in particular. And we know from Dr. Coughlin's study at Hopkins that microglial activation was demonstrated in patients with post-treatment Lyme disease syndrome compared to controls. So maybe there's a role for minocycline in these patients, and certainly maybe future PET imaging studies would be useful. And finally, IVIG for immune-mediated neuropathy that might be triggered by Borrelia burgdorferi, would that have a role? And then Dr. Katz in the New Haven, Connecticut area has been looking at this carefully, and he showed in his group of patients improvement in the small fiber nerve density and organization before and after IVIG over a 6-month period. And finally, what about modifying the GI microbiome? I know that there's a paper that is going to be coming out soon from Dr. Lewis's group on this topic, reporting the GI microbiome profile among a group of post-treatment Lyme disease patients. So are there prebiotics or probiotics that might be used? I was interested in thinking of fecal transplant, but I'm very wary of fecal transplant right now because there were 2 deaths reported in the United States related to fecal transplant, and now with COVID-19, it makes it even more scary to think of fecal transplants. So I'm not going to be doing that. To modify altered brain activation circuits, well, certainly that should be considered. We know that the brain activation circuits are abnormal in these patients, and we know that the brain is the central mediating pathway of so many of our symptoms: sleep, energy, fatigue, cognition, depression, anxiety, pain. So what about glutamate modulators like ketamine or gabapentin or serotonin and norepinephrine reuptake inhibitors for pain and mood? Or maybe targeted transcranial magnetic stimulation, which really looks like that could be quite good. And they're developing new and better ways of it and faster ways of administering it for depression, anxiety, and perhaps for neuropathic pain. So I'm thinking that the brain stimulation and brain modulation approaches should be quite powerful and should be studied. Obviously, there are many different study designs. There's observational studies, there's clinical trials. I love clinical trials. I love randomized blinded trials because they tell you something concrete, specific, and you really know something at the end. But non-randomized trials have value to some extent, and unblinded open label trials certainly give you ideas of what to do next. So finally, my recommendations for clinical trials would be to make sure that when you enter patients into a trial, make sure that they have a certain minimal, moderate level of severity on their primary outcome of interest. Some studies don't do that. It's ridiculous. They have to do that in order to really test the efficacy of a treatment. I suggest the primary target not as cognition, because I don't think that's the issue. I think it's fatigue and pain and maybe global symptom burden. Assess not only symptoms, but also the quality of life. Has the patient's quality of life improved? Has their functioning improved? Certainly attends to co-infections and other comorbidities. Absolutely store biological samples in a biorepository. Look at the microbiome before and after and during treatment to see how that's been altered. And if at all possible, make use of a national clinical trials network, because that increases geographic diversity of the strains of Borrelia. It massively increases the speed of the study, and it allows you to conduct a much larger sample size study. So we need a national clinical trials network. So thank you so much to all of our collaborators over the last few years in diagnostic metabolomics, some from throughout the United States. I won't go through them all, and also Denmark. We can't do this work without collaboration. And that's why a conference like this is so great, because it initiates new collaborations. So if you want to reach me, go to columbia-lyme.org. I'll send you my email, which I'll tell you what it is right now, baf1@umc.columbia.edu. So anyway, thanks very much.